So we're going to get started with the webinar. My name is Dr. Melissa Pasqua. I'm an endocrinologist at the McGill University Health Center, and I'm actually also a PhD student. I'm doing my PhD in type 1 diabetes, in particular diabetes technologies. So this is, not somewhat part of my niche. Today, we're going to be talking about hormones and type 1 diabetes. So the goals of our talk today are to discuss the science behind hormones in the reproductive cycle, to review the science of specific cycles in life, so in particular puberty, the menstrual cycle, and menopause, to discuss how these cycles and hormones may impact blood sugars in type 1 diabetes, and some possible strategies to help with their impact to blood sugars and type 1 diabetes care. So before I started, I wanted to discuss 5 disclaimers, okay? Just so that we're all on the same page. So first off, we're focusing on reproductive hormones. So when I first heard hormones in type 1 diabetes, as an endocrinologist, so an endocrinologist is someone who specializes in hormones. So just a reminder that a hormone is a chemical that is made by one part of the body that sends a message to another part of the body to change its biology. So for example, insulin is a hormone. So here, when we say hormones, which oftentimes in general population, we're referring to reproductive hormones. But there are other hormones that can impact type 1 diabetes, but they won't be discussed in detail. I will mention very briefly a few instances where thyroid hormones are involved, but also there's hormones that regulate stress and blood pressure. There are hormones that control bones and calcium. We're not going to be going through these in details. So we're going to focus on estrogen, progesterone, and testosterone in particular, and we're very briefly going to talk about growth hormone. So second off is that research is on the move. It's a very fast developing field of research, and there's a lot of patterns that may not be documented yet in science. So research in type 1 diabetes is developing very fast because of technologies like continuous glucose monitoring, patient registries like the Better Registry, as well as better treatment options. This, however, does not mean these effects that you may experience are not real, but it may mean that your doctor is less equipped to give you information about this in the same way as other phenomena. For example, they may have more suggestions about how to prevent lows during exercise than how to prevent lows during your period. So guidance, I'm going to guide with the best of my knowledge. There are not a lot of trials to look at how best to treat these blood sugars during these cycles of life. I will provide my expert opinion based on what I know and what treatment options are out there. I also really wanted to just highlight the difference between sex and gender. My presentation will discuss female and male based on biological sex assigned at birth. This is different from gender expression, which has a variety of expressions and may be different than the sex assigned at birth. So I want to make sure that respect concerning this difference and the different types of expressions are important. And of course, lastly, but not leastly, each person's different. So each person experiences their diabetes and hormones differently. And it's always best to discuss your patterns with your diabetes care team. Okay. So now we're going to talk about puberty. So just to introduce puberty in a biological sense. So puberty is the physical process where a child's body develops into an adult with secondary sex characteristics. So that includes breasts or beard development, for example. This is due to a change in hormones from the brain that stimulate the gonads, which are the ovaries and the testes, to wake up in a biological sense. So the hormones that are affected are testosterone and estrogen, which come from the gonads, as well as growth hormone, which comes from the brain. So in biological females, usually puberty starts at around age 8 and ends at age 13 on average. But this average is actually changing, and we're finding that females are actually going faster or more earlier into puberty than is previously recorded. But the sequence usually is breast development, then pubic hair development, then growth spurt, and then menarche, which is the term when period starts. But this, of course, can be different for each person. In biological males, usually puberty starts at age 11, so a bit later than females, and then ends at 15 on average. Then the average sequence of events is the growth of the testicles, pubic hair development, growth of the penis, then growth spurt, and then vocal changes. So puberty and type 1 diabetes. So many of the changes in puberty can change insulin needs, which can affect blood sugars. So lean body mass increases, and this is basically meaning especially the muscle mass. And muscles need insulin. So that means that there's an increased need for insulin because the body has more tissue for it to use. Growth hormone also can cause insulin resistance, and this is what's causing the growth spurt as well as some other tissues to grow. Testosterone, estrogen, progesterone can also contribute to insulin resistance. Now, they're not necessarily going to be secreted in large concentrations and then go away, or kind of reduce like in growth for growth hormone, but it will be a big difference compared to what is seen compared to childhood. So more often, more insulin than usual is usually required during puberty. Also, something to know is that on average, unfortunately, there are higher blood sugars in adolescents and young adults than in the rest of the type 1 diabetes population due to a few factors. So, of course, we already talked about the insulin resistance, but also there's a few other psychosocial aspects which can't be ignored. There's a transfer of diabetes treatment and control from the parent to to child, meaning that your adolescent might be trying to learn how to carb count and trying to take control of their diabetes, but there's a really steep learning curve. And of course, behavioral changes that might mean that doses are adjusted, that they're having some feelings, negative feelings towards their diabetes. And that can, of course, change their relationship with diabetes and also their control. However, it's still very important to take control of type 1 diabetes during this time. This is because we know that after puberty, that there's a higher risk of vascular complications. During childhood, interestingly, the blood vessels aren't as high risk for complications, but puberty and after, the blood vessels are less forgiving. So after age 15 or after onset of puberty, and also after someone's had type 1 diabetes for 5 years, your specialist will start to screen for complications. That might mean an eye exam to look for the effects of diabetes in the eyes, or a urine test to look for the effect of diabetes on the kidneys. Now, is there an effect of diabetes on puberty itself? So historically, there was a description that poorly controlled people with type 1 diabetes had a delay in growth or puberty. And this is a rare issue that we see nowadays, given current treatment options. Now, this is also because back in the day, the treatments just weren't as good. For example, people used to have to do a urine stick to be able to tell their blood sugar. So just overall, that type of treatment, and also because we weren't focusing on the goals that we do now, it was a different time. Also, just something to be aware of, people with type 1 diabetes are at higher risk of other autoimmune diseases, in particular thyroid disease. So this can delay growth if left untreated. So let's say if the pediatric endocrinologist that you're following is looking at your growth curve and there's a shift in the growth, it's very common they might do a thyroid level to make sure. In adults, there's the common, weight gain, feeling cold, all those things. That actually is not often seen in children or adolescents because the first thing that happens is a delay in growth. Now, how to address blood sugar changes during puberty? I think what's really important is to let the sugars be your guide. Someone undergoing puberty with type 1 will need more insulin than usual. So you might need to increase doses as needed. So this might mean long-acting changes, mealtime insulin, or how aggressive you do the correction. Even sometimes us endocrinologists will look and say, oh, wow, the per kilo per day, the units are almost as high as someone with type 2 diabetes, but it's not type 2. It's just the metabolism and the resistance from hormones. So this will also persist for a few years until puberty and growth are complete. Blood sugar control will be hard, but it's still very important to reduce the risk of complications. Next, we're going to talk about the menstrual cycle. So we're going to do a little review about the biology of the menstrual cycle. So every 25 to 35 days, so it's different per person, but the body undergoes the cycle of hormones which sheds the uterine lining. So the hormones that are involved are either from the brain or from the ovaries. So LH, so luteinizing hormone, and FSH, which is follicular stimulating hormone, they come from the brain, specifically the pituitary. Estrogen and progesterone, they come from the ovaries. Progesterone in particular can lead to fluctuations in insulin sensitivity during the cycle. So you might recall this picture from back in the day. Back in the day from biology class. But just to be aware that we usually consider day one of the menstrual cycle the first day of your period, and then during the what we call the follicular phase, or the first half of the period, there's just a slow increase and eventual spike in these hormones from the brain, from the pituitary, and these actually try and stimulate ovulation. And from the follicle in the ovary is secreted estrogen and progesterone. So in the luteal phase, so the second half, you can see that these hormones are secreted at a highest concentrations and compared to the rest of the cycle. And suddenly progesterone has a sudden drop in concentration. So this actually is what causes the endometrial lining to slough off and to trigger period. But if you can imagine, if there's an influence on insulin requirements, that actually might also influence blood sugars. Now, I'm talking about without contraception, because if ovulation is modified because of a contraceptive pill, it's going to completely change everything. But just to be aware, there are not a lot of studies, unfortunately, looking at this phenomenon. There are some, but they're small. So there's nothing large scale necessarily. And the studies that are done are on a few patients, and they're also on different insulin regimens. So usually it's a bit easier when we look at a lot of people with basically that are more similar than different, that we could see patterns. And also what we've noticed more recently, that you can see patterns more closely with newer technologies, especially continuous glucose monitoring. When you are checking only 4 times a day, it's obvious it's harder to find patterns. But when you see a lot of curves, 24-hour data, there's so much information. Now, I'm not expecting you to read any of these articles, but the point was more to show that this is kind of the best. There's not a lot. There's 5 studies, but also look at the range of years. What was available in 2004 is very different from what's available in 2022. And just this shows that in 2022, we're still researching this. So research is still ongoing. And it's basically from these studies, I'm going to talk a little bit of the common effects that there was a trend towards. So overall, there's kind of a trend for the estrogen and progesterone during the second half of the period, the luteal phase. It could lead to higher insulin requirements, which may cause higher blood sugars if left untreated. Now, the withdrawal of progesterone can potentially, in some people, lead to a sudden drop in insulin requirements, which may also cause lower blood sugars if left untreated. There's also other factors important to consider looking at blood sugar control and the menstrual cycle. Number one is a change in eating habits. So some people find that their eating habits change during the menstrual cycle. So obviously, if someone's snacking and may or may not be bolusing for insulin, or may have different quantity of macronutrients in the snack, that could change blood sugars. If there's cramping and pain, this can also cause high blood sugars due to the body's stress response. Also, on another important to note is that if your physical activity level is changing because of that or other reasons, this will also affect your blood sugars. It may be easier also to see the patterns with the menstrual cycle when other issues are regulated. So let's say if someone is having issues bolusing for meals, or their doses are not well adjusted, or they're having difficulty around exercise, if there's so many factors, it might be hard to see how the menstrual cycle affects things. But when other things are, basically when everything else is solved, if there's only one thing that's left to solve, it becomes a bit more apparent. There's also certain pain medications that may influence the accuracy of certain blood sugar sensors. So something to keep in mind, acetaminophen, which is also known as Tylenol, can falsely elevate levels on the Dexcom and Guardian sensors. For Dexcom, it actually takes a lot more of the drug for the more recent generations. So for example, the G6, it takes a higher dose to have an effect, but it's still a potential. Aspirin can actually, though, falsely lower levels on the Freestyle Libre. Because the sensors are different, the drug that can actually affect it is different as well. Now, what about contraceptive medications? So one analysis reviewed some prior studies, but unfortunately, these were small and just looked at hemoglobin A1C. And you can know that hemoglobin A1C is just an average. It's not going to be able to show day-to-day variations. However, there's also no evidence that there was a decline in blood sugar. So, for example, there wasn't a concern that it elevated A1C. So that's, in a way, it kind of shows a little bit of safety, but the studies weren't as good, unfortunately. However, it is possible that if a medication disrupts the cycle of hormones that are affecting insulin sensitivity, that may potentially affect blood sugars as well. Now, does type 1 diabetes influence the menstrual cycle? So previously documented that people with type 1 diabetes had less regular periods. However, this again might be from an earlier time when our treatments weren't as good. And there is something called hypothalamic amenorrhea, which is when the brain thinks you're too sick to have a period or actually too sick to be fertile. So this might be the cause. It might cause some irregular periods. But something to note is that people with type 1 diabetes are at higher risk of thyroid disease. So a menstrual irregularity may be the first sign of a thyroid problem. So I do recommend, if you are having menstrual irregularities that are new, talk with your endocrinologist or your diabetes care team. And, if you haven't had a thyroid level done in a while, it might be worth it. I want to briefly talk about polycystic ovarian syndrome, or PCOS. So PCOS is a syndrome characterized by fewer or no periods, multiple cysts in the ovaries, which are usually seen on ultrasound, and or high levels of testosterone, which you can see clinically because of high levels of acne or male patterned hair growth, or from blood tests. So just to be aware that you need 2 of the 3 to have a diagnosis. So obesity, genetics, and other factors may increase the risk of having PCOS. And also having PCOS is usually a sign of an increased risk of metabolic syndrome. So metabolic syndrome is a syndrome where you're having a tendency for higher rates of type 2 diabetes, hypertension, cholesterol levels due to a higher concentration of fat in the abdominal cavity. And this is linked to insulin resistance. So this doesn't mean, it's not necessarily linked with type 1 diabetes, but if you have type 1 and if you have PCOS, there could be a potential that you're a bit more insulin resistant. So how can we deal with changes of insulin sensitivity with the menstrual cycle? I think it's most important to look at patterns that concern you the most. So some people might actually not be bothered as much because maybe they're running a little bit higher on average. The changes, during the menstrual, during your period aren't concerning, but there might be a concern before your period. But regardless, I would discuss the patterns with your diabetes care team, and it's good to maybe have an action plan to help reduce higher or lower blood sugars. So first, we're going to talk about people on multi-daily injections, so people who use syringes or injections for their insulin. So you may want to use a separate sliding scale or insulin dosing regimen for days during your period or days right before, depending on the pattern. So kind of a quick thing that you could do, but I would talk first of all with your diabetes care team. If you're having just high blood sugars before your period, you may want to just increase your long acting temporarily or decrease it if temporarily you're having lower blood sugars. But this I would recommend, again, talk with your team, because there are certain long acting insulins that are ultra long acting that might take a while to take effect and might kind of take effect when you don't want them to. So there may be a potential that they might actually, it might be easier for you to change your short acting or your rapid acting than to change your long acting. Also, when we make adjustments, we don't double or half anything. We actually just do it in increments of 10 to 20% at a time. So for those on insulin pumps that are non-automated, so don't have an algorithm embedded in them, usually a different basal pattern is kind of an easier way to go about this. And I would discuss with your diabetes care team about creating a different basal profile. So let's say you're having higher blood sugars before your period. You can do a PMS profile or a menstrual profile if you're having low blood sugars during your period. And again, we would adjust by 10 to 20%. Another thing is you might, if you're having higher sugars and you don't necessarily want to change your doses, at least want to use your bolus calculator a lot more to combat higher sugars. Or maybe you want to have a bit more snacks that are unbolused if you're having a lot of lows during your period. So for automated insulin pumps, this system may actually adjust what you otherwise would have changed on your for your settings. However, there are some people who still on an automated insulin delivery system find issues. So I didn't write this in the slide, but there was actually interviews that were done with people on DIY looping that actually found the changes in their menstrual cycle were actually more apparent when things were better controlled. And that's kind of what I mentioned. When you solve a lot of other things, what's left, it becomes more apparent as a pattern to control. So if you're on the Tandem by Control-IQ, you can create a separate profile if you need a higher dose temporarily, and this vice versa if you need a lower dose. So just to be aware, if you need higher doses, you want to raise your basals and lower your carb ratio or correction factor, just because if you're dividing by a larger number, you're going to get a smaller number, so a smaller dose, and vice versa. For the Medtronic 670 and 770G, you may want to talk to your diabetes care team to adjust the insulin active insulin time. For you, there might be, this is usually is a parameter that's not always adjusted a lot. So the active insulin time on this pump can actually, if you lower the time, it can make the algorithm more aggressive, and when you increase it, it makes it less aggressive. So I would talk with your team before fiddling with it. By the way, this is a typo. The temporary target is 8.3, not 7.8. But with more low blood sugars, you might want to change the temporary target. And you also may need to adjust carb ratios as well. Now, for the Medtronic 780G, there are different targets from 5.5 to 6.7. So maybe going from 5.5 to 6.7 might actually help to prevent lows if that's the concern. Or if you're on vice versa, if you're usually use 6.1, going to 5.5 might make things helpful if you're having higher sugars. You may want to adjust your carb ratios as needed, but be aware this system actually has something called total daily dose tracking. So the more you wear it, the more it will learn if your insulin requirements are going up or down. So it might be that these issues may be solved if you are upgrading from the 770 to 780. So I would just if you are going to do an upgrade, I would have a cycle or two to see if those patterns are still apparent before trying to adjust things that are based on your older software. Now we're going to talk about menopause. So I'm going to talk about some terms related to menopause. The process of menopause refers to a stop in the ovulation and menstrual cycle, as there are no more eggs in the ovaries. So menopause, when it's been 12 months since your last period. Perimenopause is a time when periods are becoming less and less frequent until menopause occurs. Postmenopausal is after these 12 months. So unfortunately, there's very little data on how menopause affects blood sugars. That doesn't mean that there isn't a pattern. It's just that unfortunately, it's not well documented. However, it is clear if there was a pattern before, and if suddenly your periods are irregular, you might have the regular pattern as well, but it will usually be eventually lost after your menstrual cycles are completely done. So there was one study that found on average postmenopausal women per kilo per day were using less insulin compared to premenopausal women. However, the key is the per kilo, because if your kilos are going up, so if you're having weight gain, you might actually, if you're looking at your total daily insulin requirements, they actually might be going up. And this is because after menopause, there's a slight increased risk of weight gain, especially around the abdomen that you might be seeing. So this can affect blood sugars as well. So how do we target this? So it's important to use a calendar or an app to document menstrual cycle, and you can also document blood sugar issues as well. You may want to compare changes in blood sugars before and after each cycle. You may want to keep track of your insulin requirements. Are they going up dramatically, or are they kind of in keeping with adjustments in your weight? You may want to use similar tactics that we described in the menstrual cycle section. And also note that usually, if your weight's stable, blood sugars are going to stabilize after the menopause period. There's some word on hot flashes. So again, no data, unfortunately, on how hot flashes can affect blood sugars, but some women actually find that hot flashes may mimic low blood sugars. So a CGM is great to help differentiate the two. Now, HRT, so hormone replacement therapy, there's no data on whether it can affect blood sugars, but just be aware that type 1 diabetes itself is not a contraindication to this therapy. So if someone's saying you have type 1 diabetes, you can't be on this, that's not true. However, if you have a concern for heart disease, cholesterol, risk of clotting, or breast cancer, then that's a concern. So maybe if you're getting investigated for, some chest pain that you're having with exercise, then this might not be the time to start on HRT, because it can increase your risk of clotting and heart attacks in those who are concerned of it. So does type 1 diabetes affect the age of menopause? Interestingly, there are more studies on this than how blood sugars are affected in menopause. There were some older studies saying that onset of menopause is earlier in type 1, but there's a more recent study that showed not. So there's a bit of a discrepancy. What's something important to note that there's a rare disease called ovaries. So it's autoimmune destruction of the ovaries. And because type 1 diabetes is overall an autoimmune disease, sometimes if you have one, you can have other diseases. So just be aware there's some people with type 1 who also have this. So there's a slight increased risk. It's not that high, but it's still something that's available, that's seen in the literature. So after menopause, something important to be aware of is bone and heart health. So there's an increased risk of heart disease, stroke, and osteoporosis in postmenopausal women. These risks are further increased in type 1. So just a reminder, so in people without diabetes, there's an issue. In type 1 diabetes, there's already an issue. So it's a synergistic concern that you should really be careful for. So when it comes to bone health, it's important to do bone strengthening exercises like resistance exercise, vitamin D supplementation, and making sure you're taking enough calcium. You also might need further treatments like a bone protective pill as per your doctor. Cholesterol and blood sugar control is very important to avoid heart disease in people with type 1. So we're going to do a big summary. So I know that I talked about a lot of information, but different hormones are secreted differently at different stages of life. These hormones can sometimes affect blood sugar. Puberty is the time of insulin resistance, as well as a few other things, but more insulin is needed sometimes during these years. The menstrual cycle may cause different needs of insulin during parts of the cycle. So just be careful if there are patterns, what's happening, and to adjust as needed. These patterns will also change again as menopause occurs. Your diabetes care team is a valuable asset during this time. And I'll be honest, even if they don't know what's happening and they're not aware of it, I think it's still important to mention it, because if one person says, oh, I'm having issues during menopause, then you might say, oh, is it really menopause? But if 10, 20 people are all saying it, then it becomes more obvious that we need to be more careful, and maybe it can allow for some more research to happen. Technology is very helpful. So if you're not already on a CGM, I highly recommend it. At least in Quebec, there are RAMQ can cover a lot of CGM. So this is something that's a very important tool to be able to see patterns. Just want to talk a little bit about some studies. So there is a remote study coming out of IRCM, led by Dr. Rabassa Lore. And it's basically looking at the menstrual cycle in people with type 1 diabetes. So if you fit this criteria and you're interested, and this is by remote, you don't have to go in physically. You can do it from anywhere at home. You might want to contact Anne Bonnell at this email and this extension to see if you're eligible for the study. And in Alberta, this is not remote, this is in person. Dr. Jane Yardley at the University of Alberta is looking for people postmenopausal to join a study looking at basically high repetition, low intensity exercise, and compare it for glucose control versus a moderate repetition, moderate intensity exercise. So I would email them if you are available to go to Edmonton and are interested in the study. All right. So that's everything. I'm just going to leave on this slide. And I guess now we have some time for questions. All right. So I see already a couple of questions in the Q&A. So I'm just going to answer these live. I believe I have read that insulin can increase the amount of testosterone the ovaries create, and itself causing PCOS-like symptoms. So I think the problem is, so there is a concern that hyperinsulinism, because of metabolic syndrome, can cause issues with testosterone. It's a bit different when it comes to type 1 versus other hormones, just because, first off, the insulin is in a different part of the body, right? It's going into the blood vessels as opposed to locally. So it's not really necessarily a part of type 1 diabetes, because the hyperinsulinism that we see is usually when it's related to metabolic syndrome and a different pathology than injecting insulin. So just something to be aware of. So I wouldn't necessarily be too concerned for just people with type 1 diabetes in general. And there's nothing really much to do in terms of, at least if you have type 1. But let's say if you're non-type 1, or just because, you're at risk of metabolic syndrome, sometimes what we do is we use metformin. This is actually the why we use metformin in PCOS. And also weight management can also be a benefit, because usually hyperinsulinism is suggesting an inflammatory state because of metabolic syndrome. Hope that helps. Next, my daughter had her first cycle. I'm going to answer this live. So I'm guessing by basals, it looks like there might be. So first off, I'm always going to say if there's something specific about a patient, always talk to the diabetes care team, because I might not necessarily know about, what their treatment plan, what's their past history. So if someone's cycles are not regular. So first off, it's always possible that for the first year that there's irregularity. So something it's well documented. It's as the brain is trying to get a regular pattern. It might be irregular. So there might be skip periods, there might be more frequent periods. And we know this in the first year of when someone starts their period. So there are quite a few apps actually to be able to record things. There is actually one that they're using in the Glimetzi app. It's called PC. And there's a few apps that are available. There's also P Tracker. There's many, you can just Google them. There's many apps that are available to track your period. Even before apps were available, people would just use a calendar. So I do recommend keeping track of it. And, the certain of the apps are actually pretty much all of them. There's multiple actually. You're able to write notes. So you can say, high blood sugar, had my period today. So you can actually be able to track it so that you can look at it a bit later. Hope that helps. Okay. Any other questions? So something that was also noted, at least in the French French seminar, was asking about, is there a particular type of oral contraceptive pill or a method of contraception that's preferred in people with type 1 diabetes? So first off, it's always, I didn't get to mention here because it looks like there might have already been a talk about pregnancy and type 1 diabetes. In type 1, a planned pregnancy is a healthy pregnancy. So we do recommend, if you're not actively trying to get pregnant, to try and prevent it, just because you really need tight blood sugar control and usually an adjustment of your medications. For example, stopping certain medications that can cause harm to the fetus, and taking folic acid. It's usually better to plan. There isn't necessarily a specific oral contraceptive pill that's preferred or not preferred. It usually depends on why you're using the contraception. So is it to treat PCOS? Is it to try and treat acne? Is it for actual contraception? The one thing is that it was mentioned in the other one about what would you recommend to an adolescent. So trying to have something that is easier to use and not harder to forget might be something that's to be aware of. There have been some older injectable hormones that can cause some issues with bone density. So I would talk to your doctor about that, just because people with type 1 are at higher risk of drop in bone health. So something to be aware of. Okay. So if there's I guess no further questions, I guess we'll finish here. So yeah. So again, these I'm just going to show you these. Oh, sorry. These are the two studies that are happening. So this is remote, so virtual with IRCM, and this is in person at at the University of Alberta. Okay.